Dean College of Ayurveda Udupi to take over the session. Welcome, sir.
The next is about the facial palsy. Now, facial nerve itself has a very complex anatomy. The anatomy, significant issues about the anatomy is the facial nerve originates from the facial nucleus just above the palms, and the track would be it passes through the canal, a facial canal, and along with that a branch of the trigeminal nerve also passes through there, and it has both motor and sensory component. The motor components would be supplying to the oral muscles, and then there is a component which is following to the endocrine, this salivary gland secretions also. The palpebral muscles also are supplied by the superior branches. So that's the complex anatomy over there. And the temporal branch towards the temporal area, zygomatic branch towards the zygomatic process, and the facial muscles over there. And the buccal branch passes to
Screen is not visible, sir. Sorry to disturb.
screen is not visible.
Yes.
Why? The is the screen visible now?
Yes, sir.
Yes, sir.
Yes, sir.
Okay, now that is it visible now? Okay. Facial nerve, the anatomy would be complex branches. It has the branches of temporal, the facial, and the marginal branches which are towards the periphery of the muscles, and there is a small cervical branch too which has a comparatively less significance. The most important part there is it has both a motor as well as sensory component. The motor components are towards the facial nucleus as such, and sensory component from the other area. Along with that, there is a sympathetic and parasympathetic inflow too passing through the same facial canal, and that facial canal is the narrowest portion over there. And based upon that, whenever there is a palsy of the facial nerve, the clinical symptoms produced due to upper motor neuron lesion and the lower motor neuron lesion would be somewhat different, because the lesions which are of the upper motor area will be proximal to the facial canal, and there is a combination, or the geniculate nerve doesn't really pass through the canal there, or doesn't get affected. The appearance, the clinical appearance of the patients with the palsy would be presented with the typical identifiable manner. In a normal situation, when you close the eyes and you raise the forehead, the wrinkles on the forehead would be seen in both the sides as such uniform, and the patient would be able to close the eyes properly. In a patient with the upper motor neuron lesion palsy, the forehead wrinkles would be typically presented, or the forehead is not really affected there in the case of typical upper motor neuron palsy, and patient can raise eyebrows fully on the affected side. On the affected side, the eyebrows can be raised fully. As a, that is the typical appearance. Whereas in the lower motor neuron palsy, the forehead is involved and the patient can't raise the eyebrow on the affected side. That's the basic difference between that. Causes for the facial palsy are many. Among them, one of the most common clinical condition is the Bell's palsy, or which is commonly seen, and as usual, we will deal with only the common conditions which are quite frequently seen, and the other conditions will be just casual as such. Bell palsy is an acute unilateral peripheral lower motor neuron facial nerve palsy that gradually resolves over time in 80 to 90% of cases. This is a standard definition, and which is unilateral and considered to be of idiopathic etiology. The exact reasons are still doubted as such. The incidence of Bell's palsy is approximately around 20 cases per 1 lakh population. The cause of the Bell palsy remains unknown. though the disorder appears to be a polyneuritis with possible viral, inflammatory, or autoimmune and ischemic etiologies. Increasing evidence implicates herpes simplex type 1 or herpes zoster virus reactivation from the cranial nerve ganglia. So, these herpes simplex or the herpes zoster virus reactivation. Actually, herpes is a consequence of the reactivation of the chickenpox virus, and then when that same again this reactivates, that results in the cranial nerve ganglia, cranial nerve palsy as such. A family history of Bell palsy has been reported in approximately 4% of cases. Recently, COVID disease as well as COVID vaccine are also suspected to be a triggering cause for the Bell's palsy. Again, not confirmed, but there are reports which suggest about this issue. So, the real causes of the Bell's palsy is still not understood properly, and it's considered to be around cause for the 60 to 75% of the cases of unilateral facial paralysis. Other conditions we will discuss which are not so common, the less common conditions, we just refer to their names as such. Then right side is more affected in 63% of cases times, and it can also be with a reported recurrence range of 4 to 14%. Around recurrence is also seen in a good number of patients, and it's always unilateral or mostly unilateral. Right side is more frequently not. Persons with diabetes have a 29% higher risk of being affected by Bell's palsy than do persons without diabetes. Again, how this is related to is not known, and majority of patients with bilateral facial palsy would have either Guillain-Barré syndrome, sarcoidosis, Lyme disease, or meningitis, which are of neoplastic or infectious origin or bilateral neurofibromas. So, whenever the patient has a bilateral lower motor neuron palsy, you have to be extra careful to rule out the other conditions. A unilateral facial palsy, lower motor neuron palsy, which is of generally sudden origin, can be considered as the Bell's palsy. The most common theory, the oldest theory of the Bell's palsy is because the nerve passes through the facial canal, that labyrinthine segment, that curved segment of the facial canal, which is an arrowist, and that the diameter is just around 0.66 millimeter. There is a high chance of the nerve getting compressed over there, and that's exactly the point where the most of the patients of Bell's palsy would have an inflammatory changes or ischemic changes in the nerve segment at that area, and the anatomy is supposed to be one of the triggering causes or maybe the precipitating causes for the Bell's palsy as such. Symptoms of Bell's palsy characteristically, it's acute onset of unilateral upper and lower facial palsy, and which usually occurs within 48 hours period. Once it starts, it develops within 48 hours of period, within 2 days as such. The other symptoms could be, there could be pain behind the ears, posterior auricular pain could be occurred, and the tear discharges from the eyes could be reduced on the affected side, or there could be hyperacusis, that could be excess of the tear discharge on the other side as such. There could be taste disturbances, patients half of the tongue may not be appreciate the taste as such, or pain in the ears, otolgia is pain in the ears also could occur. Half of the patient with the affected Bell's palsy may complain of posterior auricular pain. About 50% of the patients would have that pain behind the ears, and the pain frequently occurs along with the paresis, but pain precedes paresis by 2 to 3 days in about 25% of patients. In some patients, pain is presented prior to the palsy, in some it could be together with that. Some of the other early symptoms which can occur could be, even before the palsy is fully developed, would be simple weakness of the facial muscles which could be felt by patients. A poor eyelid closure, patient may feel that he is not able to close the eyes fully, and then after 1 or 2 days he develops a typical palsy. Aching of the ear or the mastoid bone, which is quite common in around 60% of the patients. Alteration of the taste sensation, excess of discharges from the ears, or tingle or numbness in the cheek or mouth, excess of tears, or ocular pain, blurred vision also could be some of the symptoms which may occur prior to the development of a full-fledged palsy. Now, other ocular manifestations, patients once they have developed these clinical symptoms, the other manifestations which could be seen in the eyes could be, once the patient has become established that, and which is of significance, that ocular manifestations are of significance from the clinical point of view. In Bell's palsy, because 80 to 90% are self-limiting, majority of them get relieved by themselves. But the problem would be with the eyes. Damage to the eyes tend to occur due to a incomplete closure of the eyebrows, and hence the patient may have the complications, and hence this is important. The typical ocular manifestations could be either lack of thalmus, means inability to close the eyes completely, or parentic ectropia of the lower lid. The lower lid may not be able to move up as such. The cornea becomes exposed, and hence the patient would have a drooping sign. Upper eyelid would be retracted as such, or decreased tear output, or poor tear distribution. Tears would not be formed, or tears would be lesser there, and the nasolabial fold would be reduced. Corneal erosion, infection and ulceration, which is quite serious. Now, once the cornea becomes eroded, the cornea erosion occurs because of the exposure. Because the patient is not able to close the eyes fully, there is a possibility of corneal erosion, and that's one of the significant issues when you manage the patients of Bell's palsy. Then it's graded as either grade 1 up to 4 grades are mentioned, 5 grades are mentioned. Grade 1 is normal. Grade 2 is mild dysfunction. Characteristics include the following: slight weakness is noted on close inspection only, otherwise it may not be. Slight synkinesis may be present. Synkinesis is where the patient is not able to have symmetrical movement of the eyelids. That's the normal symmetry and tone are also may be noted at the rest, but when the patient attempts to move, the asymmetry could be seen. Asymmetry or unequal movements of the facial muscles could be seen. That's what we call as synkinesis. Synkinesis is asymmetry on movement as such. And when the resting conditions, you may not see the abnormality. Forehead motion is moderate to good. Complete eye closure is achieved with minimal effort. So patient may have some difficulty. Slight mouth asymmetry is noted. Then we call it as grade 2. Grade 3 is a moderate dysfunction where the characteristics are obvious but not disfiguring difference is noted between the two sides. Again, noticeable but not severe synkinesis or contraction or hemifacial spasm is present. There could be spasm of the muscles also. Normal asymmetry and tone are noted at the resting. In the resting condition, you may not see the abnormality. Forehead movement is slight to moderate. Complete eye closure is achieved with the effort. And a slightly weak mouth movement is noted with maximal effort. Then it's called as grade 3. Grade 4 is a moderately severe dysfunction where the signs include an obvious weakness and disfiguring or asymmetry is noted. Symmetry and tone are normal at rest. No forehead motion is observed, and eye closure is incomplete. Asymmetrical mouth is noted with maximal effort, and that's when the patient stretches the mouth. Then the asymmetry is noted. That's grade 4. And grade 5 is severe dysfunction where the patient may have only barely perceptible motion is noted. Asymmetry is noted at rest also. No forehead motion is observed. Eye closure is incomplete. Mouth movement is only slight. And grade 6 is total paralysis where there is a gross asymmetry, no movement. Majority of the patients who come to the clinic would be in the grade 4th or grade 5th conditions. Now, because the signs are not clearly visible, to make out, there is a standard coding system or grading system, and that's what called Sunnybrook facial grading system, where these scores are given so that the grades can be made out easily. Those who are interested in writing thesis on facial palsy, they may be able to do that. They may make use of this standard facial grading system. Of course, it's the same thing. There is nothing more than that. The abnormalities are graded with specific numbers objectively, and hence you will have a complete total scores, and then based upon that, and you may make out like whether the patient has a obvious facial palsy or not, and then this scoring system could be helpful in assessing the recovery, whether the patient is recovering or not. I think I will not go into the detail, like it's not important. Now, of course, there are certain softwares also, apps also are available which can assess the facial movement, and the facial palsy scores can be given by such apps also are available. Those who are interested in only from the academic point of view, this is significant, may not be from the routine clinical point of view. In routine clinicals also, these scoring systems can be used to convince the patient as such. Investigations, of course, in majority of the patients, you may not need a very sophisticated investigation, but investigations may be required to rule out the other causes or other underlying causes also which can trigger these conditions. Among them, one of the important is HIV screening, because incidence of that immunocompromised condition and the Bell's palsy is very significant, and hence that's necessary. Then the complete blood cell count, erythrocyte, ESR also, thyroid function studies, serum glucose levels, if necessary, CSF analysis, CT-MRI and conduction studies. These are necessary to rule out the other conditions, not to confirm the Bell's palsy. No investigation confirms the Bell's palsy. Bell's palsy is purely a clinical diagnosis, but to rule out the other causes which can produce a compression of the nerves or damage to the nerves, are needed. The other conditions which are which can affect these peripheral nerve are mainly the degenerative diseases of the nerves, or tumor pathologies, or injury to the nerves. That's the most important thing. Now, other standard tests which are again more of a theoretical interest than really practical. Very rarely we do these tests in the clinical practice, but standard tests in the case of Bell's palsy are salivary flow test, where there would be a small catheter introduced into the submandibular glands, and then the patient is asked to suck a lemon, and if the salivary flow is compared on both the sides, and the normal side is the control, if the salivary secretion is reduced on the affected side, that confirms that, which is not routinely done. This is another of the academic test. Or a blotting test also is one of that kind of a test, where the benzene will stimulate the nasal reflex, the discharges of the ears could be seen, and the degree of tearing compared between the paralyzed and normal sides, which can confirm that the tears are reduced. So, irritation with the nasolacrimal reflex by benzene is done. Or nerve excitability test is where you use a stimulus, electrical stimulus, and to confirm that, which produces a muscle twitching. So that's about the different tests which are of really high issue, not the regular issues. The American Academy of Neurology has given a guideline of the treatment, for the treatment protocol. The guideline given by American Academy of Neurology in 2012 says that the steroids are highly likely to be effective in and increase the likelihood of recovery of facial nerve. So steroids are used as a regular treatment in case of the Bell's palsy, and this is the standard protocol even now. But the basis of this is not known really. How the steroids would help, this is not known. Probably they would act as an anti-inflammatory and help in recovery from the inflammatory changes. Antiviral treatment like acyclovir or valacyclovir also is now prescribed, and combined with the prednisolone has been used in patients who cannot take prednisone. This is about the other way. So these are the basic treatment protocols which are followed in the contemporary science. Again, it more is on a guesswork than really the objective evidence-based prescriptions. Then the other most important part is eye care. Take care of the eyes. So when a patient has a Bell's palsy, the most important part is you have to ensure that the eyes do not get hurt. So the simple primary things would be use a goggle which can cover the eyes and prevent that dust or other mechanical injuries to the eyes. If necessary, you may use some eye drops, like some steroid containing eye drops, to prevent that irritation over there. Or in advanced conditions, there could be a tarsography surgery. Tarsography surgery is where the eyelids are closed, kept closed as such. Surgical options are necessary only when there is no recovery even after the sufficient times, or maybe the tarsography to close the eyes as such. And these could be very complex surgeries and rarely done, not really needed, and the usual surgery options are facial nerve decompression. Compression by making opening the facial canal, the compression of the nerve could be reduced, or the to make the eyeballs or the eyelids move and eyelids cover the eyes. You have that repair techniques where subocular ocular fat is lifted up, or implanted devices like over the eyelids so that eyes gets closed, or trastography is that closure of the eyes with the suture, or transposition of the temporalis muscles, facial nerve grafting, or direct blow lift. These are not routinely done, rarely done surgical options. Prognosis is usually in three groups. First group is where there is a complete recovery of facial motor function without sequelae, which is seen in majority of the patients. More than 60% of the patients would have a complete recovery, and incomplete recovery comes in around 20 to 25% of the patients, and where the patient may have a complete motor functions recovered, but the cosmetic defects may be slightly present over that. And group 3 are permanent neurological sequelae, and they are comparatively lesser. It's only in around 10 to 15% of the patients of Bell's palsy that there could be a permanent deformity, and in these conditions that surgical options are necessary. And prediction of the prognosis, how to predict the prognosis, this is again quite important from the clinical point of view. Most of the times when the patient comes to Ayurvedic hospital, the patient will be coming at a later stages. Majority of the patients would have tried the steroids and then they come to us. And if the patient comes fresh, then this would be quite significant. Now, if the patient shows some improvement within 3 weeks, then the recovery is most likely to be complete. So, recovery within 3 weeks is one of the important issues. If the patient comes much later, after 3 weeks of trying steroids and then comes to us, the chances of recovery would be lesser. There could be a residual defect left over. If the recovery begins between 3 weeks and 2 months, then the ultimate outcome is usually satisfactory. There could be a chance, like even after 3 weeks, if the recovery occurs up to 2 months, then there could be. Majority of the patients come at this phase where our treatment can make the changes, and then you can assure the patient like whether the patient would have a recovery or not. Now, if the recovery does not begin until 2 to 4 months from the onset, likelihood of permanent sequelae, including residual paralysis or synkinesis, is higher. So, if the patient comes after 2 to 4 months, you have to be careful and you have to predict that prognosis. So, from Ayurvedic treatment point of view, this prediction statistics, prediction of prognosis statistics is quite important. If no recovery occurs by 4 months, then the patient is more likely to have a sequelae from the disease, which includes synkinesis, crocodile tears, or that's continuous discharges from the eyes, and or hemifacial spasm. And recurrence occurs in 4 to 14% of the patients, with one source suggesting a recurrence rate of 7%. Now, these are important issues. Complications of the Bell's palsy may include irreversible damage to the facial nerve, abnormal regrowth of the nerve fibers resulting in involuntary contraction of certain muscles when trying to move others. That's again a synkinesis. Abnormal movement can occur. Tics-like symptoms could occur, or partial or complete blindness of the eye that won't close due to the excessive dryness. These are the major complications of the Bell's palsy. From Ayurvedic point of view, this is typically the description of the Ardita mentioned in Sushruta Samhita. Shirasa Bharahanath Atihasya Prabhashanath Utrasa Vaktakshavadoh Khara Karmuka Karshanath Vishamad Upadhanatya Katinanam Chitarvanath Vayu Vivruddhate Sesha Vatrehi Urtham Asita Vakri Karoti Vaktrardham Uktam Hasidam Ikshidam. So that's the typical saying. There will be deviation of the facial muscles, and it could be more prominent when the patient laughs or does some movement as well. ततोऽस्य कम्पते मूर्धा वाक्सन्दस्तब्धनेत्रता दन्तजालः स्वरभ्रंशः श्रुतिहानिः क्षपग्रहः गन्ध अज्ञानं स्मृते मोहः त्रासः सुप्तस्य जायते निश्चीवः पार्श्वतो यायात् एकस्य अक्ष्णोः निमीलनं जत्रोः ऊर्ध्वं प्रजातीव्रा शरीरार्थे अधरेऽपि वा तस्तमाहु अर्जुनं केचित् एकायामम् अथापरे. This is called as Ardita or Ekayama, and the treatment protocol would be, when the patient comes at the early stage, my prescription would be Trifala Budra Ekambira Shugandarisha and Anutelanasya, and if the patient comes within 2 to 3 weeks of onset, the recovery rate is quite high, excellent. But if the patient comes at a later phase, which is after 3 weeks, and majority of the patients come after 3 weeks, as I told you. You may need to have the other protocol of the treatment, where I would use Abhrata Tapya Libodhya a Brahmana treatment. Tailadhara or Radha also could be in the patients who have a delayed recovery. But outcome would be better if the patient comes earlier and if the patient has not taken steroids. Patients who have taken steroids and then they become resistant to the steroids, our treatment produces relatively a lesser impact as such. That's about the facial palsy, one of the important conditions. Now, some of the other conditions which present with the facial palsy but not Bell's palsy, uh, clinically they are not so common, but still occasionally you may come across that, and among them, one of that would be, which you may come across occasionally, could be Ramsay-Hunt syndrome. Ramsay-Hunt syndrome again is a facial neuropathy. The same facial palsy symptoms would occur, along with the vesicular rash or the skin in the ear canal or auricle. That is also herpes zoster like symptom, or herpes zoster oticus. It's also named as herpes zoster oticus, and which also involves the mucous membrane of the oropharynx. Is also the other name given is geniculate neuralgia or nervous intermedius neuralgia. These are all the different names given to Ramsay-Hunt syndrome in the different textbooks. And even without the skin rash, it may present as such, and typically it will be presented with a skin rash around the ears, as well as rashes in the oral cavity, and plus there would be the facial palsy symptoms. The common cause is supposed to be herpes or varicella virus as such. The clinical presentation is mainly the vesicular rash of the ear or mouth, as in as many as 80% of the patients. 20% of the patients rashes may be absent. The rash may be precede at the onset of the facial palsy. It could be before or maybe simultaneously with the facial palsy, the rashes may be seen. So when a rashes and then the facial palsy are seen, you make the diagnosis of Ramsay-Hunt syndrome as such. Then the lower motor neuron palsy, exactly as in case of the Bell's palsy, clinical symptoms are seen. Other symptoms which are also presented could be vertigo or hearing loss, tinnitus, otalgia, headaches, dysarthria, gait ataxia, fever, or cervical adenopathy also may be seen. Location of the rashes may be seen on the anterior two-thirds of the tongue, soft palate, external auditory canal, or over the pinna also. These are the areas which you have to examine as such. Complications comparatively rare, but whenever they occur, they may be presented as a brainstem encephalitis, cranial nerve filth involvement, meningitis could be the other symptoms. And prognosis, complete recovery is in more than in 50% patients. Treatment protocol, there is no difference, the same as Bell's palsy. From Ayurvedic point of view also, of course, the cases which we see would be rare, very rare. But one or two cases which I have seen, they respond to the same protocol of the treatment and response is good. That's about one of the conditions. Then another condition is Lyme disease. Comparatively, it's rare in India till now, but recently there are some reports of this Lyme disease in northern India, like particularly Haryana and Punjab. The incidence is increasing. In South India also, certain cases are reported in past 1 or 2 years. Somewhere in Tamil Nadu, a few cases are reported. A few cases are reported in Karnataka also, at the Tamil Nadu border in the southern part. At present, I have not seen a case of Lyme disease, but I think we should be prepared to see a case of Lyme disease, because the rate of spread seems to be slight increasing. So it's maybe for us it could be a disease of the future, but it's actually more common in European countries, United States and Arabian countries. In these areas, it's quite common. In India, it's reported only in some areas, zones at present, where it could be considered as an endemic. Naturally, it is an endemic disease and usually transmitted through the ticks. So, though we have not seen the patient Lyme disease, ticks are here, and any time that tick may be infected with this infecting organism, and Lyme disease may be presented, and we may be able to see the patients in future. And typically it's presented with a multisystem illness due to spirochete infection, Borrelia, and the disease is transmitted to humans via tick bites from infected ticks of the genus Ixodes. Ixodes ticks are common here, but till now it's not reported. The typical clinical presentation of Lyme disease is it presents with the flu-like illness, fever, chills, malaise, exactly like flu-like, and there could be lymph nodes involved, and there could be erythema. That reddish rashes seen, either single or multiple, is the characteristic feature of the Lyme disease. Patient presenting with fever, if the patient presents with these rashes, you have to suspect that Lyme disease quite significantly. Headache, fever, and lymph nodes enlarged, conjunctivitis, carditis symptoms, usually with the heart block symptoms, meningismus, and then the other cranial neuropathy, typically Bell's palsy-like symptoms. Cranial nerve 7 or facial nerve palsy could be presented as such, which could be paralytic and unilateral also, including the forehead. That's a typical lower motor as such. It can be confirmed by a specific test, enzyme immunoassay, which is now available. Lyme disease immunoassay tests are available. Test kits are present in now government supplies these in endemic areas, and there is some screening also in the peripheral areas. So it's one of the issues considered seriously in our health program. Lyme disease is considered as one of the serious issue, and hence I think we should be sensitive about this, though we may not see the patient immediately, but anytime it may be that we may be able to see. There is a Western blot specific test also, or a joint aspiration. Aspirated joint fluid also can be seen as microscopic issue. In the suspected meningitis CSF analysis and ECG to confirm the carditis are the other investigations which are required. Treatment protocol, standard treatment protocol, which is now the standard throughout the global is oral antibiotics for 28 days. Prolonged antibiotic is necessary, and if there is a retreatment of oral antibiotics for residual joint swellings may require this retreatment as well. IV antibiotics may be in the refractory cases, and oral antibiotics for another month in patients with positive PCR or cyanoid. So patient has to be followed up, and even after the symptoms are relieved, if the patient is seropositive, then the antibiotics may have to be given. NSAIDs in patients with the negative PCR, supplementary if necessary with the hydroxychloroquine, because of the joint pain which may persist for a long duration. And surgical treatment also is the other conditions in unresponsive conditions. As far as my clinical experience is concerned, I have not seen a patient of Lyme disease till now. So no such. Probably, suppose if we see the patients of Lyme disease, probably we can manage without antibiotics and with our usual treatment of AMA Vata conditions. Maybe it may be possible to treat as such. That's one. Then the prognosis is adult patients with early localized or early disseminated Lyme disease with erythema migrans, doxycycline or amoxicillin or cephaloxime are the choice of antibiotics. Children under 8 years and pregnant or nursing with early localized conditions, amoxicillin or cephaloxime are the choice of antibiotics. In the patients who have neurologic involvement, IV penicillin, ceftriaxone and cefotaxime or oral doxycycline are given if not contraindicated. Then associated symptoms like syncope, dyspnea or chest pain, they may require some specific treatment, symptomatic treatment like IV fluids may be required. If the patient has a AB block, then cardiac specific drugs may be necessary. Heart block could occur in case of Lyme disease, and the protocol of treating that would be followed. That's about the treatment protocol for Lyme disease as such. With this, we conclude today, and the next condition which we discuss would be about herpes and its relations issues in the next session as such. Right. If there are any questions, we will answer, and then. Can we use steroid therapy and allergic medicines combined in case of facial paralysis? Of course, the practical thing is when a patient comes with the steroid prescription, you cannot stop that prescription suddenly. So what I would prefer is taper that steroids as early as possible. We go for a rapid tapering protocol And along with that we give the allergic treatment. If the patient comes to me in the beginning before the steroid treatment is started, then in that condition definitely yes, I would not prescribe the steroids, and I have treated a plenty of patients without the steroids and the results are as good or rather better, to a certain extent better as such. So steroids are not mandatory, but our drugs can be prescribed along with the steroids if the patient is already is on steroids. That's how I manage that patient, right? Right, okay.